Uh, Thank you for that kind introduction, and thank you, Diabetes India, for having me here. I'm a hepatologist among the all the endocrinologists and diabetes specialists here. So, how will you treat MSLD? This is the question which has been given. So, the top five treatment options for treatment for fatty liver or MSLD. The first answer would be the lifestyle measures to achieve weight loss. Second would also be lifestyle measures. Third, fourth, fifth, and in the last, 10th would come as the pharmacotherapy. So lifestyle, there's the no getting away that lifestyle measures are the most important measures to achieve weight loss and then treat MASLD. And we have seen this pyramid a multiple of times that if you have achieved about 10% weight loss, then your fibrosis, liver fibrosis, would also reverse in about 50% of time. The holy grail of MASLD treatment is reversing liver fibrosis. So if you are able to achieve weight loss of 10% by any means, you do not need any drugs. So basically, for lifestyle measures and achieving weight loss of 10%. So if there's in bland fibrosis, you can target only 3% weight loss, but if you have advanced fibrosis, at least 10% would be required. So, what are the drugs for treatment of NFLD after lifestyle measures? So, the drugs can be divided into two groups: one that target the NASH or the liver component, and the other which target the weight reduction. So, I would not be talking about the weight reducing drugs because there's a it's a topic in itself, but nonetheless, that GLP-1 agonist and various other dual and triple agonists are coming a long way in weight reduction. So I'll be talking about drugs which are actually targeting the NASH or the liver component. Again, GLP-1 comes here, but going by one, coming to the thyroid agonist, it has been discussed before also. So NAFLD or the MASLD is associated with both clinical as well as subclinical hypothyroidism. We have seen so many patients of hypothyroidism, they have coexisting MASLD, and similarly patients of MASLD who have coexisting hypothyroidism. But that is clinical hypothyroidism. There could be also a subclinical hypothyroidism which is in the liver itself. So low serum thyroid level hormones and high TSH levels are associated with fatty liver. Thyroid hormones are linked with lipid metabolism, and many studies have found that if we treat these patients with T4 agonists, even they have normal thyroid function, it reduces the liver fat content. But obviously, we cannot treat these patients with thyroid hormones. So, long-term treatment with thyroid hormones is in a euthyroid patient would lead to lots of adverse effect. So NAFLD patients have got intrahepatic hypothyroidism. So what happens that T4 is in normal liver, T4 is converted into T3 inside the liver, but in the MASLD patients, this is not able to happen, and T4 is not converted into T3, and then RT3 or reverse T3 is being formed. So what happens? This new drug, which is resmetirom, which corrects this anomaly. So it acts on thyroid beta receptors inside the liver, and it changes the gene expression, and this conversion, which is inactive RT3, is prevented, and then it leads to favorable lipid metabolism inside the liver, and it decreases the hepatic fat content. So it's FDA. This is the only FDA approved drug so far, and it comes by the name of Rezdiffra. And as the registration trial was called as the Mastro trial, which was published in NEJM last year in February, just a year back. So it enrolled patients who received either placebo or resmetirom 100 milligram or resmetirom 80 milligram, and the endpoint was either resolution of inflammation in the liver, that is NASH resolution, or improvement in fibrosis. and the results was that it was able to achieve both. It reduced the liver inflammation, it reduced the fibrosis, and so both 80 milligram and 100 milligram of resmetirom were superior to placebo with respect to NASH resolution as well as improvement in liver fibrosis by one stage. And so based on this, FDA approved the drug in within 1 month of this publication of the NEJM study. It has got very mild side effects, nausea and diarrhea, but the major side effect is the cost it will cost to your pocket. This is about $3,900. So very expensive, as Dr. Basu mentioned. However, it has been included in the guidelines. These guidelines, which are EASL guidelines, which were EASL and ESD guidelines published last year in June, they mention that resmetirom can be used in these patients if you have biopsy proven MASH. Coming to other group of drugs, that is GLP-1, and in this entire diabetes conference, it has been mentioned or discussed in almost all sessions. So I need not go into details what are GLP-1 agonists and what is incretins basically. So incretins are GLP-1 and GIP hormones, and these hormones are responsible for the incretin effect. So this slide I've been showing to all gastroenterologist colleagues who may not be aware, but it's we need not show here. So basically, incretin effect is that when you have increased insulin secretion in response to oral glucose as compared to the IV glucose, and it is mediated by gut-derived hormones, that is GLP-1 and GIP, and the receptors are widely expressed, especially in pancreas, and apart from their lungs, then heart, kidney, and especially in the brain, because that leads to satiety. So both GLP-1 and GIP receptors are expressed at many places. So there are three hormones which are now being targeted: GLP-1 agonist, GIP, and glucagon. So, as I mentioned, the receptors of GLP-1 are there in the pancreas, but apart from pancreas, they are located at multiple places: liver, brain, heart, GI tract. And if we give this GLP-1 agonist, the action would be similar to the the native GLP-1 hormone, and will have the same incretin effect, and will increase the insulin secretion, and it has got beneficial effects in the liver. It decreases the hepatic insulin resistance. It corrects the de novo lipogenesis and also decreases hepatic fat deposition. So many GLP-1 agonists are available. These are the cost, and almost all of them are injectable. And this was the trial of semaglutide, which was published in 2020. It showed that it could lead to improvement in inflammation. This was a phase 2 trial, but in the phase 2 trial, it did not show improvement in fibrosis, and it was mentioned that probably the duration was less, and had it been continued for a longer duration, the fibrosis would also have been improved. So the ongoing phase 3 trial is called as Essence trial, which is still going on, and which is enrolling a lot of patients. The interim analysis was published just about 2 months ago in November 2024, and it did show improvement in inflammation as well as in the fibrosis. So this was a interim analysis about 800 patients. In India, semaglutide injectable is not available. We have an oral form that is available in the doses of 3 milligram, 7 milligram, and 14 milligram. You all are aware about it. And the adverse effects, apart from the GI adverse effect, the adverse effect is on your pocket because it's an expensive drug. Coming to the other targets, if to the GLP-1 agonist, if we add GIP, which will also have various other targets apart from pancreas, and then if we add the glucagon agonist, then we can have dual agents or the triple agents. One of them is survodutide, tirzepatide, and retatrutide. So the phase 2 trial on survodutide was published in June last year. It did show that there was improvement in inflammation, but again the holy grail could not be achieved, that is, no, there was no improvement in fibrosis. However, a phase 3 trial is still ongoing on survodutide. Coming to the tirzepatide, it is again a dual agonist. The trial on obesity was published in 2022, which showed that it could reduce body weight by 20 to 25%. And the trial on MASH or NASH was published in June 2024. It did show improvement in inflammation, but again could not show improvement in fibrosis. Coming to the retatrutide, which is a triple agonist, that is both GLP, GIP, as well as glucagon agonist. So the phase 2 trial was published just about a couple of months back. It showed this was in obesity phase 2 trial, which was published few years back, which showed a 25% reduction in obesity, which actually matches the bariatric surgery. With bariatric surgery, which you can achieve 25% weight reduction, and same now you can achieve with the triple agonist. So this trial on MASH was published in June 2024, and it was not a biopsy based trial, and they did non-invasive marker, and it was shown that it could reduce 25% weight loss as in others, but also 50% of reduction in liver fat. So this this is a significant advantage. So again, within 48 weeks, about a higher dose could reduce up to 90% of reduction in liver fat. So to summarize, the dual and triple agonist survodutide phase 2 trials are there. Phase 3 ongoing. Tirzepatide phase 3 ongoing. Retatrutide again showed significant liver fat reduction. Again, phase 3 trials are ongoing. Coming to SGLT2 inhibitors, you all are very well aware of SGLT2 inhibitors. I need not go into the mechanism of action, which is urinary loss of glucose. So this was a retrospective study conducted in Japan on 16,000 patients, and then propensity score analysis was done, and they compared SGLT2 with DPP4 agonist, and it was found that although the change in HbA1c level was more with the DPP4 inhibitors, but SGLT2 inhibitors had significant reduction in ALT levels, and also changes in FIB4. That means there was some reduction in fibrosis also, which was achieved by SGLT2 inhibitors. And also they showed that in some of these patients, even esophageal varices development could be delayed, or even not achieved if they use DPP4, but it could be achieved by SGLT2 inhibitors. So lots of meta-analysis on ALT reduction has been there, and also reduction in FIB4. So SGLT2 are good drugs, and this was a comparative trial on multiple oral diabetics drugs, which was published last year. It compared many of the oral anti-diabetic drugs, and it found that SGLT2 inhibitors are among the best of them, all the four which were compared. GLP-1 agonist was not compared in this. And among the thiazolidine and DPP-4 sulfonylureas, SGLT4 have the best NAFLD outcome in these patients. And another SGLT2 is lecogliflozin, and it showed a significant improvement in NAFLD. And there's been a comparison between SGLT2 versus GLP-1, and this was a large meta-analysis, and we found that SGLT2 are as good as GLP-1 receptor agonist, and definitely they are better than pioglitazone. Pioglitazone has been used for many years after the PIVENS trials, but now at least SGLT2 inhibitors are better than those for fatty liver disease. There are some risks on using of SGLT2 inhibitors, but benefits outweigh the risk. The risks are only in genitourinary infections, and they also, you all know very well that they have SGLT2 inhibitors have cardiovascular benefits, and these drugs are available in India. I would skip my talk on, I mean, portion on PPR agonist because this has already been covered in detail by Dr. Supratik. I would just mention that we also did a small study on saroglitazar, and where we enrolled about 90 patients, and we found that and the patients who could achieve weight loss, it was also the cap values as well as LSM values in fibroscan was had decreased with saroglitazar. So it's an excellent drug with very minimum side effects. And ongoing phase 3 trial in USA is still going on when we are waiting their results. There's one the pan PPAR agonist, that is lanifibranor. Again, it's this has one drug which has shown a reduction in phase 2 trial has shown reduction in fibrosis as well as inflammation. And again, it's phase 3 trial is ongoing, which is called as native 3 trial. Coming to FXR agonist, I'll not cover this in detail because the major drug of this was the obeticholic acid, and it had come with a good with a bang, but again it was not approved. The Regenerate trial was the phase 3 trial on obeticholic acid. It showed reduction in fibrosis but no reduction in inflammation. So it's a paradox where most drugs show reduction in inflammation. So it is available in India, although you can use it as off-label use for NAFLD patients. And there's been exploratory analysis that it does improve outcomes, but still FDA denied its approval, and then the drug company has stopped further following this. There are many other drugs like pegozafermin. These are FGF21 analogs, and the trial, this phase 2 trial was published in 2023. It showed good response. Then no talk of NFLD drugs complete if I don't discuss the landmark PIVENS trial, which compared pioglitazone to vitamin E and placebo, which was published in 2010 by Dr. Arun Sanyal. And it had shown vitamin E in non-diabetic patients was very good, and pioglitazone was also beneficial. There are many other drugs which are undergoing clinical trials, and many combination trials are also going on, and some of them have shown promise. And what in India I would do, I would combine GLP plus SGLT2, but the cost would be very much. Then PPAR agonist saroglitazar can be combined to SGLT2, and then off-label combination of OCA or obeticholic acid with PPR can be combined, and this combination, one drug will reduce fibrosis, the other will reduce inflammation, so you can achieve a good benefit. So lifestyle measures are the mainstay of treatment. First, we have to ensure that and emphasize to our patients that lifestyle measures are the mainstay of treatment. Any drug therapy would be add on to the lifestyle measures. For Indian patients, semaglutide oral, which is available as SGLT2, saroglitazar, pioglitazone for lean diabetic. Uh, if there's no diabetes, then saroglitazar and vitamin E. And off-label use in non-diabetic, we can use semaglutide if they are obese, and OCA also as off-label use. But in next 5 years, the market would be flooded by multiple NASH drugs. Thank you for your patience today.